This contrast MRI scan, the paranasal sinuses, displays a large intensity enhancing mass occupying nearly the entire nasal cavity on the right side. As we can see, the skull base appears to be intact without any involvement of the dura or in breach, and the lesion is extrasphenoidal. The sphenoid sinus can be seen to be clear and patent, as well as the frontal sinus. The CT scan on the bony window shows very clearly that the lesion is expansile and well demarcated, does not appear to be heterogeneous, and apart from some focal erosions of the lamina papracia, mostly it is intact. Also, one can see the intactness of the skull base, though the tumor is approaching it superiorly, right to the level of skull base without causing any obvious bony erosion. The septum on the left, on septum is grossly pushed onto the left side because of the pressure of the mass. The same corneal cuts demonstrate the intense blush on contrast enhancement and some heterogeneity of the contents, but we do not see any major vascular voids as the ones that we see in very vascular lesions such as angiofibromas or paragangliomas. So what we see here is an grossly expansile sort of a mass, which most likely has to be benign, but it definitely is enhancing, raising concerns about the potential vascularity. As you can see, it's pushing and not infiltrating in contact with all the walls of nasal cavity, septum, lamina papracia. The maxillary sinus on the right side is grossly squeezed and pushed into a very rudimentary small sinus because of the tumor, and it occupies the entire cavity right till the level of the anterior nares, leaving no space. We can see the heterogeneity of the contents, and the possible diagnosis could be, a schwannoma of the lateral nasal wall. It could be a mesenchymal tumor, hemangiopericytoma, also called a solitary fibrous tumor in today's nomenclature. So we do not have a histopathology, and we do not wish to take a biopsy in the outpatient. This patient was planned for surgical excision straight away. Now, as we can see that there is no dural breach or nothing, and that gives you some assurance to reduce the vascularity and to create some space for ourselves because it occupies the entire nasal cavity. We begin with gentle bipolar coagulation of the tumor surface. As you can see, the tumor is very well encapsulated, smooth margins. There is no ulceration. There is no growth-like pattern that you see in malignancies. And gentle bipolar coagulation over as much of the surface helps because these kind of tumors cannot be removed en bloc. And since we are doing an endoscopic surgery, the tumor removal shall be piecemeal, and we will have to dissect and manage intratumoral, which could lead to bleeding. So here we are using a lot of irrigation along with the bipolar diathermy as much as we can on the surface of the tumor. So of course, the central contents would remain to be vascular, most often supplied by either branches of phenopalatine or the anterior ethmoidal, or both. So obviously the fact that the tumor occupies most of the space in the nasal cavity doesn't give us much space, hence we cannot go far posteriorly here, but whatever amount of surface can be coagulated, we definitely would before we breach the surface to first take a biopsy, and then of course use a microdeviative blade to start removing it piecemeal quickly. Now, as you can see, the anterior surface, some bit of the medial, and now we are coagulating some bit of the superior surface. You can see some vessels coming here, and we are using the bipolar wherever we can to slightly decrease the vascularity of this tumor. I mean, not know how vascular this would be, maybe not much, but that's only to be told once we open it. So as we can also assess here that one is very evident that this tumor is not taking any attachment onto the septum or to the floor of nasal cavity, which again shows you that the nature is not similar as to what you see in angiofibromas or even fibrous tumors, because they start taking attachment and more vascularity. So this looks like a tumor that is not taking vascularity, merely occupying the entire space in the nasal cavity. And because of its growth and size, it starts to compress and push onto the neighboring structures like the lamina papyracea, the nasal septum, the medial wall of maxillary sinus, and the posterior wall as well. And we see here, though the space is very less, we can just take a slight bipolar lateral to it, not much space. And now once we have reached the tumor capsule to take biopsies, we straight away take a microdebrider blade and we start debriding this tumor. Now one can see that post-coagulation or otherwise as well, despite the fact that it was markedly enhancing, the tumor does not display a lot of bleeding. But even to check the rest of bleeding, what we do is we go to the core of tumor. Rather than debriding the entire surface, we create a core inside the tumor. We keep decoring it, or to remove the central core of tumor and to leave behind a thick shell outside, which we could start dissecting and find out the attachments as to where it attaches itself to. So as we can see, the microdebrider core is very elegantly able to clear the central myxoid sort of a core of this tumor without much bleeding. The slight amount of oozing can be managed with a sucker inside the cavity, as well as with some constant irrigation from the assistants. It's very important to not continuously remove the endoscope every now and then as the scope gets soiled because of some bleeding, because that invariably wastes a lot of time and leads to frustration. And in all these tumors, however vascular they are, because if you stop and you take out the scope and you keep putting it inside, that wastes a lot of time. So we keep on irrigating as we are operating, and then the assistant can obviously add one more suction. Also fairly well. So once we have decoded reasonably okay, then we start seeing with the attachments. And then again, since it is too big to find out attachments, we can simply start removing some bit of it using an endoscopic scissors to make it debulk it and to see the exact points of attachment. See, medially and inferiorly, we can at least remove the inferior portion of it substantially and leave behind the superior lateral attachment, which would be mostly the point where it attaches to the lateral nasal wall and achieves its vascularity. Because that is where we will need to get some clearance of this tumor, and the rest of it can be simple. This much a little bleeding is quite okay. And this most certainly is not how angiofibromas bleed. They're much more vascular. They're not so soft. They cannot be debrided. They are fibrous, thick tumors. So this does not look to be very fibrous and sort of more myxoid, so to say. And nerve sheath tumors often behave like this. The key is to, again, like I said, keep operating, keep debulking it time and again, because the lesser the tumor surface, the lesser the overall bleed. The bigger the tumor surface, the bigger the overall bleed. So as we keep debriding it turn by turn using a variety of instruments and equipment such as suctions, thick, big suctions, the microdebrider blade, endoscopic scissors, in some situations, eventually we would reach to a point where we would be able to identify the actual attachment or the origin of this lesion. And that is the most important key point in this surgery. So a relatively softer tumor is a very good tumor to be removed using microdebrider. Hard fibrous tumors, of course, will not be removed through a microdebrider, but softer tumors obviously can be removed fairly well. As we can see, the most of the inferior half of the tumor has already been removed by intratumoral surgery through the microdebrider, which is rather quick and helps us manage the bleeding as well as the vision, which is most important in these patients. Now, one thing to note is that as of now, we have still not gone towards the choana. We are going towards the choana, but we haven't seen. Now we can start seeing the glimpse of choana, which is very important because in this kind of situation where the tumor has expanded the entire nasal cavity, the landmarks are grossly distorted. And to make any sense of where you are and how you must go, since we know that the tumor is taking attachment superior towards the skull base, we need to be able to see the first and most consistent landmark, that is the choana, to be able to see the level of the nasopharynx, the sphenoid sinus, and the posterior wall of septum. And as you see, all of these areas are relatively free. So which basically leaves us only the superior and the lateral, or the superior lateral attachment, which seems to be our area of concern. Now, as we use our suction, we can now see a choana, and now overall, it is much easier to generate a perspective as to how this tumor is attached and what is our three-dimensional reconstruction in our mind of surgery. And this, as you see, as we push the tumor slightly medially, we start seeing thick mucin coming from the frontal sinus, the frontal recess. And this we also saw in the MR, that the frontal sinus had no tumor, but just T1 hyperintense contents. And now you see, as the moment we have pushed the tumor medially, the frontal sinus seems to be very, very clear. There is no polyp there. There is no unhealthy mucosa. There was just pent-up secretion which have been cleared. And now we are able to see that this tumor actually takes attachment to the lateral nasal wall and the site of the origin of the middle turbinate. Now we will use a coblation bond on the ablation settings so that we can directly go to the bone and get this tumor off by not just pulling, but simply ablating the entire mucosa surrounding the lesion right till the roof of nose. As we go toward the roof of nose, one must appreciate that the attachment is in fact anterior to the frontal sinus. So this roof is not really the skull base, but this is basically the anterior part of the bone that forms the base of frontal sinus, and the actual cribriform plate is behind it, behind the level of frontal sinus. And now, as we remove the attachment, or using the coblation from the most anterior and lateral nasal wall, we see that the most of the attachment of this lesion is to the middle turbinate itself. And now, once we are clear that the affected mucosa has been removed by coblation right to the bone, now we can start removing it from the middle turbinate itself, as we would do probably a middle turbinectomy, right till the roof of it. One can see here that the nasal skull base itself appears to be free because the lesion is affecting and attaching itself to the middle turbinate only. And now, as we start removing the middle turbinate and along with this the lesion superiorly, we keep using our scissors gently and slowly keep pushing the tumor downwards to see if we are missing any attachment or leaving behind any attachment. As of now, we do not seem to be, and this lesion seems to be just arising from the middle turbinate. And as we remove the middle turbinate itself, the lesion is getting cleared. We can now start seeing the ethmoidal skull base. As you can see, a glimpse of the anterior ethmoidal artery is also visible from lateral to medial, and the entire fovea ethmoidalis, along with the cribriform plate region, is now in our vision. Now, as we use the suction, we see the small opening of the sphenoid sinus coming on as we remove this lesion still and keep dissecting and keep cutting it from the superior attachments. Now, one thing, of course, is as we're seeing whether it is the ipsilateral sphenoid sinus on the right side or the contralateral, because the septum is grossly pushed towards left side. This could be either the ipsilateral or the contralateral sphenoid sinus. Now, again, it's important to appreciate that there's no tumor being left behind. We are not pulling the tumor as you would pull a polyp. While we remove it, we are very conscious of the fact that where is the attachment, and have we left any portion of mucosa, unhealthy mucosa, or diseased tumoral mucosa over anywhere of the lateral nasal wall, which seems to be not the case. Once it has been cut, from the attachment of the middle turbinate, we can simply remove this tumor. And now what would remain? Now you see the tumor is completely removed. There is no attachment anywhere. And as we said, we will just shortly confirm with the navigation probe that this is indeed the contralateral sphenoid sinus. It is basically the left-sided sphenoid sinus because the septum is crossly pushed from right side. And the ipsilateral sphenoid sinus will be more medial to this. Now to locate the ipsilateral sphenoid sinus, we use our bone punch, Hedgehog-Koffler bone punch, and we peel off some more portion of the residual middle turbinate bone to be very, very sure of not leaving behind any portion of the tumor as well. And there we're using the Koffler bone punch to remove the residual portion of the middle turbinate posteriorly. So as you see here, this portion of the turbinate bone is also being removed. And now we're very certain that our disease clearance is complete. The entire base of skull, the foveal roof, the frontal sinus, the contralateral sphenoid sinus and the coena are all visible clearly in front of us. You can even see a markedly ischemic portion of the septum because of the shear pressure. And some bit of excess redundant mucosa is now being cleared using a microdebridor blade. And now what is left is, of course, to clear the ipsilateral sphenoid sinus and to clear any pent-up secretions from the same. You see here the instrument is going inside the frontal sinus with this anterior ethmoidal artery being clearly visible on the base of skull. Rest of the foveal roof. And as we dissect this laterally, you would in some time soon come towards the ipsilateral sphenoid. It's the navigator probe which shows us the anterior ethmoidal vessel here, as you see, very clearly going from the orbit right to the skull base before it again comes back into the sinuses to supply the anterior and superior portion of the nasal septum, branch of the ophthalmic artery. The frontal sinus itself is clear. So as we see here, our navigation probe points to the fact that this was indeed the contralateral sphenoid sinus. And now we will go right medial to the leftover attachment of the tail of middle turbinate, excise middle turbinate, to find and locate the ipsilateral sphenoid sinus because of the cross pushing of the septum towards the other side. So as we see here, we are again using our bone punch to increase the, to do the sphenoid osteotomy on the ipsilateral side. And as we do so, we immediately open the sphenoid os on the ipsilateral side. Now one can obviously understand and correlate the fact that above the coena, in this side, you find both the sphenoids with the intersphenoid septum. You see here the secretions have been cleared. This is the sphenoid on the ipsilateral side, because of the fact that the septum, because of the tumor, has already been pushed. So the sphenoid is clear, as we had seen on the MRI scan, just some secretions, no evidence of disease in the sphenoid sinus. Probably we can just leave it as such, or maybe slightly enlarge it for gentle irrigation in the post-operative period. While enlarging it, one must be cautious as to not injure the septal branch of the sphenopalatine artery unnecessarily, because it would not make any sense in this situation since the procedure is already done. Just a generous sphenoid os opening is required, and you can see that there's nothing much but just some clots and retained blood and secretions, and no evidence of disease or any altered mucosa. So this is again, we see that this is a frontal sinus navigation probe, just to reaffirm the fact that we are indeed inside the frontal sinus, to reaffirm the anatomy in our mind as to how it is once the tumor is removed, because the anal cavity on the right side is markedly expanded and pushed, and one can see the entire skull base on the posterior wall of frontal sinus very well. This is, of course, the maxillary sinus on the right side, which we had seen is has become very small because of the tumor pushing onto it. So very small, just above the inferior turbinate, you can locate the maxillary antrum, which is basically now nothing but a small. This is an all anatomical perspectives noted.